And now it's my great pleasure to introduce Professor Dennis Jensen. Welcome, Dean. Professor Jensen is professor at the UCLA in Los Angeles, and to introduce him is either very difficult or very easy. You can also say I'm introducing the Pope of GI bleeding. Everybody who deals with GI bleeding knows him and knows his papers. He has published more than 300 papers, a lot of reviews, book chapters, and was involved of many guidelines. And I think one of his most outstanding achievement was the Rudolf Schindler Award, which really is, I think, one of the highest privileges for endoscopists. And congratulations to this wonderful award. But now I think you were now the first doing a randomized trial on a special technique with a over the scope clip. And in Germany, we did a study, the STING trial on recurrence bleeding, and we were also involved in this study, and we realized this is a nice technique, which is very, very successful. And now the consequence was that a couple of trials are now running as the first line treatment, and your paper was published first. And I'm really happy to have you here. Good morning to Los Angeles or lunchtime. Thank you for being here, and thank you now for sharing your data with us and discussing this paper, which will be discussed later on with Ian Gronick. Thank you, Dean.
Well, thank you for that kind introduction and your comments, and happy 2022 to everyone. I hope it's better than last year. So this was published in CGH. Actually, it was published online a year ago, but just recently in print. I have no disclosures to make, nor do others. This was initially funded by the ASGE and an award, and in part by the NIH through the Human Studies Corps, which I direct. By way of background, at least here in high-risk patients, recurrent bleeding from ulcers and Dieulaloy lesions is common. And we have published in Gastro not too long ago that standard visually guided treatment is associated with 26% recurrence rate, which was significantly reduced if you used a Doppler probe to get rid of the underlying arterial signal. We think that the Avesco obliterates arterial blood flow underneath stigmata better, and that's from an observational study that I'll show you the data at the very end. When this was planned and finally published, there were no treatments or reports, randomized trials of initial hemostasis for non-variceal bleeding. And our purpose in this one was to do such a trial and compare it with current treatment, which here is either hemoclips or multipolar probe with or without pre-injection of epinephrine. The specific aims then were to compare the outcomes of patients with these two treatments. And the primary outcome was more bleeding, which is either continued bleeding or rebleeding within 30 days. Secondary outcomes were the usual, including severe complications, deaths, transfusions, and hospital days after randomization. This was conducted at UCLA and the VA, where I work. It's registered for those interested in clinicaltrials.gov. Initially, patients with severe bleeding were admitted to the hospital were screened according to criteria that I'll go over with you. And after randomization, importantly in this trial, the primary caregivers, including the ICU people, were blinded as to the endoscopic treatments that were administered. And they made all the decisions about whether the patient should have further treatment for rebleeding, whether they should have transfusions. They were not given the discretion about treatment, which included PPIs, of course, in the ulcer patients. So patients who at endoscopy met clinical and endoscopic criteria for either having major stigmata of hemorrhage or a flat spot with the Doppler showing under arterial or blood flow underneath it were randomized in a 1-to-1 allocation by opening a sealed envelope. The outcomes were as usual managed here with SAS and analyzed by our UCLA biostatistician. The inclusion criteria included clinical parameters, which you're familiar with, laboratory evidence, and transfusions. Secondly, life expectancy of at least 30 days, age over 18, written informed consent from either the patient or a surrogate, and then the lesions I described with either having active arterial bleeding, oozing bleeding, non-bleeding visible vessel, adherent clot, or the flat spot as mentioned with the Doppler positivity. Exclusion criteria were do not resuscitate, uncooperative patient or unable to consent, GI or other malignancy with survival reduced, an ASA of 5 or moribund, shock unresponsive to usual medical treatment and transfusions, severe coagulopathy with platelets less than 20,000 or INR greater than 3, or PTT greater than 2 times normal in spite of blood products. Some absolute contraindication to urgent EGD, such as suspected perforation, and then a stricture of the foregut. If a patient had cirrhosis with a recent diagnosis of varices and banding, or ENT source of bleeding, or portal hypertensive gastropathy bleeding, they were excluded, and as were patients who had esophagitis, Cameron ulcers, angiomas, or UGI cancers as the site of bleeding. So this is a consort diagram. Originally, there were 346 patients assessed. 200 were excluded because they did not meet clinical or laboratory criteria. 146 were consented. 93 were excluded because they did not have endoscopic criteria. Many of them had clean ulcer bases, for example. Of the 53 randomized, 28 were allocated to standard therapy, and all of them received it, were followed for 30 days, and 25 were allocated to the Avesco, and similarly were followed for 30 days. Nobody was lost, and no one died in this trial. This shows a challenging ulcer, a very large or giant duodenal ulcer with a visible vessel here and some oozing observed earlier to be spurting. It was injected with dilute epinephrine. And this shows the challenge of placing, this is an 11-3A clip, a Vesco clip, pushing it through the pylorus, centering on the stigmata, and then finally deploying this device. And that's not always as easy as it looks, and it requires some extra training, which we did in models and with videos among all the investigators who are skilled endoscopists here. I'm not going to go over all of this, but these are the baseline characteristics, which are well matched with the Avesco in the middle and standard there. Whether you look at the types of lesions, most of which were ulcers, the stigmata of hemorrhage. Of note is that the ulcer size, the median size was 11 to 12 millimeters, with almost 50% of these patients having ulcers greater than 15 millimeters in size. The only difference on this was the PTT, somewhat higher in the Avesco group. Other characteristics are shown on this slide and summarized in the paper. It's of interest, as you might know, at least in the United States, HP positivity is rare. Most of these are NSAID ulcers or related or idiopathic. And regarding the ASA classification, we had high-risk patients, quite a number of them ASA 3 and 4, and a few with cirrhosis. As to the primary results, the 53 patients as shown were well matched. However, the 30-day rebleeding rates were significantly higher in the standard group. That was 8 out of 28, which is 28.6% compared with the Avesco group, 4%, highly significant by log rank test. This rebleed rate in the Avesco group was 90% lower than the standard group. Shown here are the confidence intervals. Importantly, clinically, the number of patients needed to treat is only 4. These show the Kaplan-Meier curves for all patients. And most of the rebleeding in this case occurred within the first 4 days, although there were a couple of delayed bleeds. These show other outcomes of interest, and the complication rate was higher in the standard group. I'll discuss that in a second. Also, the number of transfusions after randomization was higher. Arithmetically higher are the hospital days and the ICU days. What were the complications? Well, they were related to further bleeding: 1 stroke, worse heart failure, 1 aspiration pneumonia, and 1 bleeding ischemia related to embolization that was done. So bleeding here, it's interesting. They don't always transfuse the patients because there are restrictions which are reported from Spain in a New England paper, but that really does not pertain to the type of patients we see here with many comorbidities. They need to be transfused probably to a hemoglobin above 8. So the results by Stigmata of Hemorrhage, for patients who had oozing bleeding, that's Forrest 1B, or flat spots, Forrest 2C, none of these patients had rebleeding, whether they were treated with standard hemostasis or the clip. They would not benefit from Avesco. You can use just standard hemostasis on them. On the other hand, patients who had major stigmata, that is active arterial bleeding, visible vessel, or clot, in the standard group accounted for all the rebleeding, which was 34.8% of them, compared with 5.9% in the Avesco group. So the number of needed to treat of patients with major stigmata is only 3.5. And they're the ones that would benefit most from this large clip. Shown here are ulcer patients, the subgroup, which is the largest group, and the Kaplan-Meier curves, again, which are highly significant. Just looking at ulcers, the number needed to treat is 4.2. Looking at patients who have major stigmata of hemorrhage, similar findings. Number needed to treat is 3.5. So it's of interest to compare the STING trial, or pardon me, of Schmidt et al., as Helmut referred to, and our trial. These are quite different in methodologies and also in some of the results. They had 66 patients compared with ours 53. That was focused on retreatment of ulcer bleeding, whereas ours was initial treatment of either ulcers or Dieulaloys. Blinding wasn't done of the caregivers in the Schmidt trial. It was in ours. The number of centers was 19 in the Schmidt trial, and it's just 2 in ours. Pre-study investigator meeting for standardization of techniques was not apparent in the Schmidt trial. We had that fairly rigorously, as we have in other trials. crossover for more bleeding was permitted in the Synmed trial. It was not in ours, which allows us to report other 30-day outcomes. The PPI infusion standardization was not obvious or stated in the Synmed trial, whereas we made it quite mandatory to the caregivers. As far as standard therapy in the Synmed trial, most of them had hemoclipping or injection, and there were very few with cautery or multipolar probe, whereas with ours, there was an equal distribution of hemoclipping and MPEC. The funding in our trial was NIH and the ASGE, and then the Synmed trial was the company, Avesco company. And as far as the outcomes reported by Synmed et al., there was further bleeding at 7 days and also for crossovers. And we reported not only further bleeding, but the other complications, ICU days, et cetera, post-randomization transfusion. So these are complementary studies, and it should be that the societies look at these for rewriting the standard of care and their guidelines, in my opinion, because they are randomized trials, evidence-based. I've already stated the conclusions for you. I'm going to emphasize a couple of points. This shows a picture of the Vascular Technology Doppler box and catheter, disposable catheters, which are available. They cost about $150 US, these things, and are very useful for detecting blood flow. To emphasize the importance of blood flow, in several studies that we have done with ulcers, shown in green is the residual blood flow, shown in red are the rebleeding rates. So if you have residual blood flow after your standard treatment, you're going to have a high or correspondingly high rebleed rate within usually 4 days or so. If with successful Doppler guided treatment, you get rid of the blood flow, 0 of 63 ulcer patients bled. With the Avesco, as you saw, we studied this of the one patient who had residual blood flow with the Avesco, that patient rebled. So the message here is blood flow is important. And the last slide harkens back to Swain's old data with gastric ulcers. The goals of hemostasis are not just to control active bleeding, but they are to prevent rebleeding. And the way you do that is to obliterate the underlying vessel, which is an artery, and you can guide that by Doppler quite well. This is a major risk factor, that is residual arterial blood flow underneath stigmata. Thanks for your attention. Glad you're interested in this paper. These are hard studies to do.
Well, thank you very much, Dean, for this very interesting talk. And I think the results that you presented are very impressive and convincing. This paper will be commented by Professor Ian Grolnek from Israel. He is a clinical professor of medicine and gastroenterology. And he is also, as you all know, the president-elect of ESG. Helmut called Dean the Pope of GI bleeding. I would say that maybe Ian is the chief cardinal of GI bleeding, and really a second best. And therefore, I would ask Ian to comment on this paper.
Peter, thank you very much. That was a very kind introduction, and thanks, Helmut, for inviting me. And yes, I realized I didn't know I was trained by the Pope. I feel very important now, Dean. I've known Dean for 30 years, believe it or not, which is sort of frightening. But I commend Dean and the UCLA Cure Group on another overall well done clinical trials. And I agree with Dean. These are not easy trials to run. I was there when some of the early trials were done, and really Dean has put his heart and soul and his entire career looking at this, and he should be commended for it. I just want to show here is that, Dean, we did use this study. It was online. I know it just came out, but we did use the data from the study to help inform the updated guideline from the ESG on non-variceal upper GI bleeding. This is just the flow diagram from the updated guideline that was published almost a year ago. And of course, with the high-risk endoscopic stigmata, the Forrest 1As and Bs and Forrest 2As, of course, we recommend endoscopic therapy. For the active bleeders, it's combination therapy. For the F2As or the non-bleeding visible vessels, it can be thermomechanical or sclerosing injection as monotherapy or in combination with dilute epinephrine. Where we also utilized some of Dean's work is when we looked at actual persistent bleeding. So in other words, where standard endoscopic therapies were not working, we suggested that in patients with such persistent bleeding that was refractory to standard hemostasis, that we should be using a topical hemostatic spray or powder, or what we call a cap-mounted clip, and I'll explain why I say cap-mounted clip momentarily, should be considered. Now, this was mainly expert opinion at this point because this is a weak recommendation with low quality evidence. However, we did use Dean's data and the data from the STING trial to inform our recommendation on recurrent bleeding. So these were patients who initially had primary hemostasis, but then subsequently had recurrent bleeding. And we do recommend that for such patients with recurrent peptic ulcer hemorrhage, that the use of a cap-mounted clip, such as the over-the-scope clip from Movesco, should be considered. And this is a strong recommendation with moderate quality evidence because there are now 2 randomized controlled trials that have, in one way or another, looked at this question. So the reason we've called it a cap-mounted clip is because commercially there are 2 of these types of clips available. There's the Movesco over-the-scope clip. There's also what's called the padlock from Steris. But the vast majority of data looking at GI bleeding and the use of cap-mounted clips is really with the Movesco device, which was used in both the STING trial as well as in now Jensen's study. So what are the other data? We've heard a little bit about this. The initial study, this was a retrospective multi-center European study, looked at 118 patients with non-variceal upper GI bleeding using over-the-scope clip as first-line endoscopic therapy. This is called the FLET-ROCK study. And basically what they showed in this retrospective observational trial was that at least when using the over-the-scope clip, there was significantly less rebleeding in patients who were considered to be moderately high risk by Rockall score or at high risk, defined as a Rockall score of 8 or greater. They also found that there's significantly less mortality in those patients who actually had evidence of rebleeding in the high risk Rockall patients. Overall, they found there was primary hemostasis using the over-the-scope clip of 92%. I'm just going to show very briefly, this is a video that shows use of the Movesco over-the-scope clip. This is it's really sort of an oozing, there's a small ulcer there. This is not a Dieulaloy lesion. This is a small ulcer in the antrum. And this is just showing use in a slightly pulsatile bleeding lesion, use of the over-the-scope clip. And I'll start this other one now. Get that running. And you'll see here, I don't know why it's running so slow, at least on my computer, it looks like it's running slow. You'll see here then that the clip is deployed eventually. And as we've heard from Dean earlier, the main goal here really is to obliterate the underlying artery. And what is nice about using the over-the-scope clip is that you grab a large amount of tissue. And this is probably likely why you're not only getting good primary hemostasis, but you're also showing less rebleeding in studies. Let me go on to the next slide. This is from the Mayo Group. This was also published in 2018. They looked at this again. This was a retrospective observational study that looked at patients with high risk lesions, non-variceal lesions, but it was both upper and lower GI bleeding with a high risk for adverse outcomes. And really what they found is that when using over-the-scope clip, They had a efficacy of about 72%. And then lastly, we've heard about the STING trial. I'm not going to go through this again, but again, these were patients who had recurrent ulcer bleeding. They were then randomized to either standard hemostasis or over the scope clip, and they found that significantly less further bleeding in those patients who were randomly assigned to receive over the scope clip. We heard about this from Dean before. I'm going to also show this video. Hopefully this is going to work a little bit faster. This is from Dr. Marine Camus from Paris. This is a very nice video, and I'll show just parts of it. This is a very large fibrotic duodenal ulcer that was just not able to be stopped from bleeding with standard endoscopic therapy. You can see there's a through the scope clip there. They're injecting here, but this is a very large fibrotic ulceration where I find that over the scope clips are extremely useful. There is a learning curve for this, and there's a little video here that shows Marine loading this onto the scope. It is somewhat similar to band ligation. So the learning curve, in my opinion, is not that steep. It's quite similar with the Ovesco device, very similar or analogous to using a band ligating device. And you'll see here then that the scope is now reinserted after the clip is loaded. And Marine finds the area where the bleeding is. And you can see here it has been deployed and the bleeding has been stopped. But it can be very effective in these large fibrotic excavated ulcerations. So a few comments here, and I'll ask Dean a couple of things here. I think there were definitely study strength. This is, of course, a randomized controlled trial. Subjects were blinded. The clinical care team that was caring for the patients were blinded to what treatment they received. Overall, it was a well-designed protocol with appropriate endpoints. And of course, these were very experienced investigators who are well known in doing randomized controlled trials in GI bleeding. Now, having said that, of course, there are some limitations. There are limitations to every study. There were a limited number of subjects. Overall, there were 53 subjects that were included in this trial. There was somewhat unequal distribution by randomization in terms of there were more Forrest 1As or active bleeders that were actually randomized to the standard hemostasis group, and more of the Forrest 2C lesions, the flat pigmented spots, to the over the scope group. And I guess my one question to you, Dean, is do you think this made any difference? In other words, because you had these active bleeders and there were more that were by chance randomized to standard therapy, do you think that impacted maybe some of what you saw in your endpoints and your outcomes of the study?
Well, we don't have any evidence for that. We were able to stop the bleeding in all of them. And I think that some of these lesions are deceptive. They may not be bleeding right the same way as when the patients present, and they are slowed down a little bit. Some of them have been treated with PPIs, which may modify it somewhat, but it's the underlying artery that's the problem. And the other thing that I would emphasize is the size of the ulcers. Based on earlier trials about size of ulcers, something that's 15 millimeters or bigger is high risk. And basically all of the major stigmata have a very high high rate of finding an artery underneath. So in spite of what you see visually, it's what's underneath that matters. And we don't have a way of sizing the arteries, but some of them with standard hemostasis are very hard to treat, either coap or you think you clip, because of these through the scope clips are not very strong. So I think it's a deceptive, we're fixated on this, Forrest classification. And I think we need to go beyond that. We need to combine that with what is blood flow. So do I think that it made a difference? No, we've done more patients. We have about 60 patients now. There's more balance, and it doesn't make any difference. The results are just the same.
So that sort of brings me to one of these other points here. I'm going to skip over the Dieulaloy, but because I know you guys have done this work using the Doppler probe, and I understand exactly what you're saying. So one of the issues, I guess, that some of us would say is that impacted the stratification because it was not currently, it's not the norm right now. The question is going to be, and how generalizable is it? I understand, I hear what you're saying. The question is going to be, Dean, are we going to have to adapt from visual or change from visual stigmata to where use of a Doppler probe to measure underlying blood flow becomes more standard? Because right now it's not standard. People, that's not routine. People are not using this routinely. Can you
Well,
just
they should.
comment about that a little bit?
They should. It's inexpensive. It's available. You can buy the box for under $2,000 US, and the catheters cost $150 or so. If you're going to improve hemostasis, not everybody's going to be able to use nor afford a Vesco. They cost, quite a bit of money, $500 to $800 US. I don't know in Europe now, but you guys may get a discount, but I don't know. So if you're going to improve hemostasis, is a very simple technique with ulcers. There are many other applications, including preventing delayed post-polypectomy bleeding and using it as a risk stratification. So the results are generalizable because in this trial, the only way Doppler was used, the only group it was used in was a flat spot group. And we only enrolled patients who had flat spots, who had an artery underneath, because we know that happens in flat spots about 45% of the time, and about half of them rebleed if you don't treat them. So that's the only group. So Doppler, on this trial, Doppler was not involved. I gave that as background information. But no, I don't. I think if you have patients with flat spots, you can treat them with anything. Oozing, you can treat them with anything.
But do you recommend, if you see a flat spot and you had the ability to use a Doppler probe, do you recommend to use the Doppler probe, and if you see a signal, you would then basically bring that flat spot from a low risk lesion to a high risk lesion?
Well, it's not. It's an intermediate, but because the rebleeding rate is around 20%. The point is, I would treat it if it had it underneath. And I will tell you, with diverticular bleeding, which we're not talking about here, if you find a spot on the neck or in a diverticulum, the rate of finding an artery is about 85 or 90%. And if you leave them alone, most of them rebleed. So it's very different in other lesions. So, I mean, spots are only visual. And the point here is, why wouldn't we use some new technology beyond what we can see? EUS uses it. They use Doppler in neurosurgery, urology, every other field. Why wouldn't we use it? I think it's a cohort effect that people weren't taught to use it. It's very simple to use. It's inexpensive, and it improves outcomes. But again, in this study, don't be confused. Doppler is not driving this study. It's a visual stigmata, and those are generalizable if you teach people how to use them.
Okay, so my final thoughts are, because we're really over time right now, I thought overall this is a good study. I think it's absolutely novel. It significantly adds to the GI bleed hemostasis literature. I think that more randomized trials are needed, and I think we're going to see that. I think we're seeing an increased use of products like the over-the-scope clip. I think that the learning curve of using something like the OTSC is manageable. And I think that this type of a device should be in our hemostasis toolbox. And Dean, I think you and everybody at Cure and West LA VA need to be commended on doing what is a very difficult randomized controlled trial. So kudos to you guys.
Thanks.